All right. Hello. Thank you for joining us today. So I'm Shamini Selvaraja at University Health Network. I'm a molecular geneticist at Genome Diagnostics. Joining me is Dr. Alan Spatz, who is Chief of the Division of Molecular Genetics at the Jewish General Hospital in Montreal. Also joining is Dr. Andreas Papadakis, who is a research associate working with Dr. Spatz at the Molecular Pathology Center. So the purpose of today's webinar is to discuss the role of FGFR testing, which has received actually quite a bit of attention recently due to its importance in bladder cancer, as well as the clearance of Janssen's Balversa erdafitinib by FDA and Health Canada last year. And Balversa is the first FGFR kinase inhibitor that has been approved by the FDA. So the way we have structured this talk is that Dr. Spatz will first cover the epidemiology and clinical features of bladder cancer and also touch on the management of localized and advanced disease, as well as some of the prognostic features that determine the management. I will then discuss FGFR alterations in bladder cancer, as well as review the testing process, sample requirements, as well as the reporting of the results for the testing, which will be carried out by UHN and the Jewish General Hospital. So these are the two sites that are currently being funded by Janssen to perform FGFR testing for a select group of bladder cancer patients across Canada. So I'm going to now turn this over to Alan to start with the first part of the presentation, but I'll be back in a bit. Alan?
Thank you very much, Shamini. Can I have the first slide, please?
Yep.
So let's start by some epidemiology data on bladder cancer. So bladder cancer is frequent, is the sixth most common cancer in Canada. This has been confirmed by the recent report from the CRS in 2020. And the lifetime chance of developing bladder cancer, as you can see, is 3 times higher in men than in women, with a cumulative lifetime risk of 1 in 22 men and 1 in 75 women. This makes that bladder cancer is the 5th most common cancer in men, the 9th most common cancer in women. And it's important to realize that 90% of the patients with bladder cancer are older than 55 years of age. Next slide, please. The recent CRS report estimates the number of new cases in Canada of 12,000. And this means that advanced bladder cancer is the 8th leading cause of cancer death in Canada, with an overall 5-year survival rate of 76%. And this varies very much according to the anatomic stage, with excellent prognosis in stage 1 that drops drastically to 70% in stage 2, 34% in stage 3. And the 5-year survival rate at stage 4 disease is very poor, with a survival rate that is below 5% currently. Next slide, please. So the classic presentation of urothelial carcinoma is that the patient presents painless gross hematuria with irritative bladder symptoms that will include dysuria, urgency, frequency of urination, and nocturia. Sometimes there is a pelvis or bony pain, and in some instances, the patient presents with a lower extremity edema that actually is associated with iliac vessel compression. And at the clinical examination, sometimes there is a palpable mass on physical examination. So there is a very important cellular classification that actually is associated with prognosis and cellular grading. So the first component is that the transitional cell carcinoma represents the vast majority of the epithelial cancers, with 90% of all bladder cancers. You can see this on the left part of the slide. The TCC, or transitional cell carcinoma, begins in urothelial cells. The second category that is much rarer is the squamous cell carcinoma It happens in less than 5% of the cases. It develops in the bladder, classically in response to irritation and inflammation that is sometimes identified histologically. There are rare situations with adenocarcinomas and even rarer situations of other types of carcinomas like the small cell carcinomas. Next slide, please. So importantly, there is a very important distinction between the low-grade and high-grade transitional cell carcinomas. This grading system is very prognostic. It's based on architecture and cellular abnormalities as assessed under the microscope by the pathologist. The low-grade carcinomas rarely invade the mascular layer, and when it's invasive, has limited spread to local organs. It's classically associated with good prognosis. This opposes to the high-grade carcinomas that have a strong tendency to invade the muscular layer. There is a propensity to the spread to adjacent organs, and these high-grade carcinomas are more likely to be treated with multiple modality therapies. This is also important because as we are going to discuss, the involvement of the muscular layer is a major prognostic feature. This leads to the two categories of bladder cancer, the non-muscle invasive bladder cancer, or NMIBC, opposed to the muscle invasive bladder cancer, or MIBC. So as the name indicates, the non-muscle invasive bladder cancer are only located to the lamina propria, that is the subepithelial conjunctive tissue, but not in the muscle. And on the contrary, the muscle invasive bladder cancer, or MIBC, involved the bladder muscle wall. You have on the right side of the slide the anatomic layers with the urothelium, then the lamina propria, and then the muscularis propria that is just beneath the lamina propria. Next slide. So as for any other cancer, there is a TNM staging of urothelial carcinoma. So as we said, we have two categories of cancer, the NMBCs and the MIBCs. So the first category is represented only by stages 0 to 1, based on the T category. So the TA, which is very unique to the urothelial carcinoma, is TA is non-invasive papillary carcinoma. TIS is urothelial carcinoma in situ. And then T1 represent the tumors that invade the lamina propria, but not the muscularis propria. When there is an invasion of the muscularis propria, then we switch to stage 2. So the stage 2 is represented by an invasion of the muscularis propria. Then you have the stage 3 that are usually for 3A and 0. Only the category of N1 is in the stage 3A. And when there are the lymph node categorization is switched to N2 or more, then the patient becomes a stage 3B. It's also important to underlines the prognostic feature of extravesical invasion into perivesical organs, as we are going to see on the next slide. Here you see on the right part of the slide, then T3 and T4 are the tumors that invade the perivesical tissue and organs, whereas the T2 invade the muscle, but they stay localized in the bladder. Next slide, please. So all of these together represent a situation that can be summarized on this slide. 60% of the bladder carcinoma present with a low-grade non-invasive disease, opposed to 40% with higher grade and a higher T. At the staging level, 60 to 70% of bladder Carcinomas are represented by TA and carcinoma in situ with 20 to 30% as T1, only 30 to 20% are referred at a higher stage, and 20% of the patients have a machine invasive disease at diagnosis, and of course, these patients have a much poorer prognosis than the 80% of patients who have not muscular invasive disease at diagnosis. In urothelial carcinoma, the presentation with metastasis, at first presentation, only 5% of patients have metastatic disease. Next slide. So this slide summarizes the current standard of care for the management of localized disease. The diagnosis usually starts by what we call a TURBT, cystoscopy and resection with a transurethral resection that allows the pathologist to make the separation between non-muscle invasive and muscle invasive lesions. The non-muscle invasive are split in three categories: TIS, TA, and T1. T1 in two sub-categories based on grading, low grade and high grade. So TIS and TA can be treated by intravesical chemotherapy or observation for the TA. For the T1, whether they are low grade and can be treated by intravesical chemotherapy, or high grade changes the situation. When they are high grade, it goes to cystectomy. For the muscle invasive tumors, T2A and T2B, for patients who are candidate for surgical cystectomy, then the cystectomy is usually done, followed by chemotherapy. And for the non-cystectomy candidates, then the patient is treated by radiotherapy with or without chemotherapy. The situation is obviously different when the patient presents with a metastatic disease. So when there is a muscle invasive situation and or metastasis, so with the metastasis, the patient is treated with 4 different options. The first option is a first-line cisplatin-based combination systemic chemotherapy. Second option is a first-line carboplatin-based regimens or single agents, like including taxane or gemcitabine. The third option is a first-line checkpoint inhibitor when the patient is eligible. And the fourth option is a targeted-based platinum therapy with targeted agent. Next slide. So the situation is very much evolving, like for any other cancer, based on 2 different situations: the post-checkpoint inhibitor era and the arriving of emerging targeted therapies. So in 2016 and until 2016, no major improvement was done in the therapeutic efficacy for metastatic urothelial carcinoma. And for 30 years, the situation has basically stayed the same. In 2016, 2017, it was the time of the checkpoint inhibitors revolution, and the CPIs were approved for urothelial carcinoma. This represents a very substantial change in the management of metastatic bladder cancer. And in 2018 and nowadays, we are in an era where we do have newly approved and emerging targeted agents in the bladder cancer. And this represents another challenge, which is to define the best combination and the best sequence of targeted agents and immune therapy. Next slide.
Okay, so I guess I'll take it from here, Alan.
Okay.
Thank you. So as Alan mentioned in the previous slide, clinical management of advanced bladder cancer has improved over the past few years, and a lot of it is owed to novel immunotherapies. However, one thing to keep in mind is anti-PD-1 and anti-PD-L1 monoclonal antibodies yield a tumor response in about only 1/5 of the treated patients. because of this need for alternative treatments in bladder cancer, there has been a growing interest in defining, identifying, and targeting oncogenic pathways. So in the past few years, there have been numerous molecular profiling studies, including the TCGA project, as well as the LUN study, to name a few, that have led to the classification of muscle invasive bladder cancer into various molecular subtypes. So in this figure over here, what you have is a TCGA classification, and this shows all the different subtypes that are based on transcriptomic features that they have found, as well as possible sensitivities to therapies based for these different subgroups based on the molecular and clinical pathological characteristics. Now, DNA as well as epigenetic alterations have been identified in up to 60% of bladder cancer. Importantly, targetable alterations involving the fibroblast growth factor receptors have been found in about 20% of muscle invasive bladder cancer, which makes these molecular aberrations highly attractive for pharmacological inhibition. So the FGFR family contains 4 highly conserved transmembrane tyrosine kinase receptors. You have FGFR 1, 2, 3, and 4 that have about up to date 20 identified ligands. So with the ligand binding, you have subsequent dimerization of the receptors, and this leads to phosphorylation of all the intracellular tyrosine kinase domains. This leads to activation of a cascade of downstream events, including MAPK pathway, STAT pathway, the PI3-AKT, and several other pathways that have critical roles in a wide range of physiological cellular processes. But in addition to these normal physiological processes, FGFR signaling components are also frequently altered in cancer. And depending on which gene is altered, the type of genomic alteration, and the cellular context, aberrant signaling can contribute to carcinogenesis as driving mutations, promotion of angiogenesis, as well as rise of therapeutic resistance. So, as I mentioned, FGFR genetic abnormalities have been found in several types of cancers. So this slide here highlights a study in which nearly 5,000 tumors representing over 200 different malignancies was sequenced and queried for alterations in FGFR 1 to 4. What they found is FGFR was altered in about 7% of the tumors, and the signaling pathway is actually the most commonly mutated tyrosine kinase signaling pathway in cancer. So the frequencies of aberrations and relative types of aberrations for the tumors with over 75 FGFR different cases is shown over here. And as you can see, urothelial carcinoma is the one that has the most frequent, is the one that has the highest number of FGFR alterations. So here you have the color or the legend representing the different FGFR genes, which is what you see over here. And FGFR3 is the most common in bladder cancer. In addition, it also has appreciable frequencies of amplification, mutations, and rearrangements. You also have other tumors such as breast, endometrial, ovarian that have quite a bit of FGFR alterations, but it seems like bladder cancer has the highest number. So you saw with the urothelial carcinoma, they have the highest frequency of FGFR mutation. And this slide over here shows the frequencies of the various FGFR mutations. So FGFR3 is the most commonly mutated, so that's about 22%. And then you have FGFR1. Now, FGFR3 can be aberrantly activated by several mechanisms in bladder cancer. And the left panel here shows that for FGFR3, that's this slice over here, this the activating mutations are mostly missense. And there are about 13 different missense mutations that have been reported. However, it's only a handful that are found in exons 7, 10, 15, and 19. And collectively, they make up over 85 to 90% of the mutations of FGFR3. And the way in which the activation occurs is these mutations generate novel cysteine residues that leads to ligand-independent dimerization and constitutive activation of the receptor. The second type of FGFR activating mutational events are actually rearrangements or fusions. So what happens with fusions, you have a chimeric protein that contains, with the exception of the final exon, it has an entire sequence of FGFR3 that is fused in frame to different C-terminal regions of the fusion partners. And this also leads to aberrant activation of the downstream signaling pathways. So given these established roles for aberrant FGFR signaling in oncogenesis, there was a keenness in finding a strategy in which FGFR can be inhibited in bladder cancer, especially since about 20% of bladder cancer patients will have these mutations, and in muscle invasive, 16 to 20% will have FGFR3 mutations. So when you're looking at targeting tyrosine kinases, there are two broad classes of drugs that can be used to inhibit tyrosine kinases. You have the small molecule inhibitors and you have the monoclonal antibodies. And the one that we're going to be discussing during the course of this talk are the small molecule inhibitor category, specifically Janssen's erdafitinib and Balversa. So erdafitinib, Balversa is an oral FGFR tyrosine kinase inhibitor that targets FGFR 1, 2, 3, and 4. And that demonstrated clinical activity in a phase 1 trial where patients with various types of solid tumors with activating mutations in FGFR were enrolled. And because of the anti-tumor activity in the phase 1 trial, it led to the initiation of a phase 2 multi-center trial where bladder cancer patients who had metastatic or surgically unresectable tumors with specific FGFR2 and 3 mutations were enrolled. And the response rates were quite promising. And so due to this, on April 12th of last year, 2019, the FDA granted erdafitinib accelerated approval for patients with locally advanced or metastatic urothelial carcinoma who had susceptible FGFR2 or 3 alterations when the disease had progressed during or following platinum-containing chemotherapy, including within 12 months of neoadjuvant or adjuvant platinum-containing chemotherapy. So this was significant because it's the first time that a tyrosine kinase inhibitor targeting FGFR was approved by FDA. And on October 26th of the same year, last year, Health Canada approval, a notice of compliance was issued. So with the approval, 2 labs were approached by Janssen to offer FGFR testing to identify patients who were eligible for treatment with FGFR inhibitors. So the 2 sites funded is the Genome Diagnostics Clinical Laboratory, UHN, Toronto, as well as the Molecular Pathology Lab at the Jewish General Hospital in Montreal. So both the labs are assigned different provinces. So the patients are split across Canada. So Genome Diagnostics in Toronto will cover patients in Ontario, Alberta, Manitoba, and Newfoundland. And Jewish General Hospital will cover patients, the testing for the patients in the province of Quebec, British Columbia, Saskatchewan, New Brunswick, and Nova Scotia, and Prince Edward Island. So the slide over here, I just have the two groups of provinces split up. So to facilitate the testing process, there is a document that both the labs have put together that will be circulated, and this includes the specimen and shipping requirements, which are quite important to adhere to with regards to the 2 reference labs that are designated for the specific province. So for specimen requirements, there are a few things that are very important to follow. One is that this requires external pathology review with the corresponding circled H&E slide. So the hospital that is going to be sending the specimen to either the molecular pathology lab at the Jewish General or to UHN has to make sure that the slide already went through pathology review at their own site. The FFPE block is what is preferred if possible, and we'll be taking out a 3mm core for this. If a block cannot be sent, then slides sections on slides will suffice. So for this, we will require about 8 unstained sections that are about 7 microns thick each, with an H&E slide that is cut before and after the serial sectioning. And again, the area that contains the tumor has to be circled. Small biopsies, you can always contact the lab for details. For co-biopsies, the entire block is required. Once again, it's very important that there must be at least 20% tumor cellularity, and the region with the highest tumor cellularity area has to be circled by when the external pathology review is performed. And also on the requisition, whether you're sending it to Toronto or Montreal, it's important to include tumor cellularity. So when it comes to transurethral resection of bladder tumor specimens, we just want to point out that it is the deep or invasive part of the tumor that must be sent for testing. And this is actually based on the results of a study, a multi-center study that looked at tumor heterogeneity in invasive bladder cancer specimens. So the study on these TURBT specimens found that when you're looking at tissue where the superficial part had FGFR3 mutations, about half of the specimens where the tumor had invaded into the muscle did not have the mutation in the deep part. So this implies that it is the deep part of the tumor that needs to be assessed if anti-EGFR treatment is concerned. So this is something that you need to keep in mind when you're sending the specimens over here. Shipping requirements, again, this will be included in the one-page document, but just to highlight a few things. The slides or the blocks must be sent to the testing lab immediately after sectioning or preparation, preferably in an airtight container. Each slide must be labeled with the patient's name, date of birth, and MRN number, along with the site-specific clinical requisition form. The slides need to be shipped in the appropriate protective package, placed in a biohazard plastic bag, which along with the requisition must be shipped in an appropriate shipping package with a biohazard label. And the specimens have to be sent to your own designated testing lab. So depending on where you're located, which province you're located, you will be sending it either to the Molecular Pathology Center at the Jewish General Hospital or molecular diagnostics at University Health Network. Now, if any of the specimens do not meet the specimen or the shipping requirements, we will unfortunately have to reject these, which will of course delay testing for the patient. So we would like to avoid that. So currently both sites will be using the same platform for performing the sequencing. So this is going to be the Oncomine Comprehensive V3 assay from Life Technologies. This is an RNA-DNA panel that detects variants in over 143 cancer genes that are relevant to published trials and clinical research. And because it also has an RNA component, it will detect not only SNVs, indels, hotspots, and CNVs, but also rearrangements and fusions. However, for the purpose of this testing, we will only be reporting on variants that will be identified in FGFR 1, 2, 3, and 4. Now, before going forward, I also want to highlight that when it comes to reporting these variants, when the clinical trials were enrolling the patients, the bladder cancer patients, they all had pre-specified FGFR alterations that were tested for in a central lab. So these were, the patients had to have one of these 4 FGFR missense variants, or they had to have one of these 4 fusions involving FGFR2 or FGFR3. In the current testing that'll be done by us and the Jewish General, we will be reporting on any clinically actionable FGFR mutations other than the pre-specified ones that are found to occur in 1, 2, 3, and 4. So even though we're doing this, we do want you to note that there is no data on the performance of erdafitinib on the variants other than the pre-specified ones that are listed above. So annotation of the variants that we will identify with the sequencing will be performed using a somatic variant scheme that was published by Mahdia and al. At UHN in 2016. So this actually came out a few months before the 2017 ASCO CAP-AM standards and guidelines. So this schema used at UHN is a 5-category somatic variant classification system, and it uses or assesses 4 key factors that are considered necessary when interpreting the significance of a genetic variant in somatic tumor molecular analysis. So this scheme has 4 considerations that are considered as important in classifying somatic variants. So one is pathogenicity, another one is primary site and tumor histology in which the variant is found. Third one is variant recurrence in cancer, as well as current evidence for clinical actionability. So this classification system actually uses actionability as a core principle, which is defined as the ability of the test result to modify patient management. Now, the annotation that is performed will actually go through a number of processes. So this assessment has 2 major steps. So in the first one, we actually put the variants through an inclusion criteria, and this inclusion criteria looks at the sequence data quality and also the frequency of the variant in normal germline population databases, so that anything that is considered benign will not be included in this criteria. We also will be looking only at variants that are above 5% frequency. Once a variant is put through this inclusion criteria, we'll go on to perform the annotation. So for this part, the variance observed frequency in the patient's primary tumor site, in which case bladder, and histology will be determined. And we'll be doing that using databases such as COSMIC, or TCGA, or locus-specific databases if they exist for a somatic if they exist containing somatic variant information. We will also be looking at the impact of the variant on the biochemical activity of the protein and or cellular pathway as determined from literature or in silico prediction algorithms if that is not available. And we'll also be looking at the evidence for clinical actionability through a detailed search of the literature, as well as through compendia of cancer-associated variants such as My Cancer Genome or the CIVIC database. So using this assessment protocol, we have a 5-category somatic variant classification system that classifies the variants 1 through 5. So for the purposes of this test, though, both the testing sites will be reporting variants falling within classes 1 to up to 3A. And these represent variants that can be used to direct patient care based on the occurrence in bladder cancer or in another disease site or histology where they're known to have an impact on the protein. So now that I've gone through the reporting, so this is again just to show that these are the classes that will be reported. So I just want to wrap this up by listing a few take-home points. So as Alan mentioned, about 20 to 25% of bladder cancer patients will have muscle invasive disease, and these patients will either present with or later develop metastases. Of the muscle invasive bladder cancer patients, about 16 to 20% will have FGFR3 mutations. There is now Health Canada approval for erdafitinib or Balversa for patients with locally advanced or metastatic urothelial carcinoma who have susceptible FGFR2 or FGFR3 genetic alterations that have progressed during or following platinum-containing chemo, including within 12 months of neoadjuvant or adjuvant chemotherapy. So far, there are 2 referral labs in Canada. This is the Clinical Genetics Lab at UHN, as well as a molecular pathology laboratory at Jewish General Hospital in Montreal that are funded by Janssen to perform FGFR testing. We will be reporting on sequence changes as well as rearrangements in FGFR 1, 2, 3, and 4. And these mutations will be annotated according to a somatic variant scheme by Madeo and al. There will also be a one-page document containing all the specimen as well as shipping requirements and guidelines with a hyperlink for the lab requisition. And if you have any further questions, you can always contact your designated lab to clarify any queries that you may have. I think that's pretty much it. Alan, have I missed out anything? Or Andreas, have I missed out?
Oh, it was great, yeah.
Okay, so I guess that's pretty much about it. Thank you very much for your attention. And once again, you can always contact the labs that are designated for your province if you have any questions. Thank you.
Thank you. Okay.